The first talk is going to be given by Dr. Avi Cohen. You know, Avi um, uh, uh, is part of our interventional pulmonology group. He's going to talk to us about percutaneous tracheostomies. I think it's a very important topic. He has done a very good review of it with the latest articles also about what could be doing or some other people could be doing in the COVID area. So this is a very important topic that is very likely that we'll start doing it very soon in the ICUs. So without further ado, I want to pass it on to Dr. Cohen.
Thank you, Javier. Dr. Diaz, can you guys hear me okay? Dr. Diaz, can you hear me okay?
I can hear you fine.
Okay, great. All right, so we'll go ahead and get started. Today's topic will be percutaneous dilatational tracheostomies. I'm hoping by the end of this lecture, you'll be able to describe the clinical and technical aspects of performing and even managing tracheostomies that have been recently cannulated. Once the tracheostomy is done, you should know what the risks and benefits are of performing them early or in mechanically ventilated patients in the ICU, how to manage the complications that can be associated with the tracheostomies, both early and late. So first, we'll start with the epidemiology of invasive mechanical ventilation in the ICU. Overall, as you can see, the patients that require invasive mechanical represent only about 3% of the hospital admissions, but they're about 12% of the hospital costs, costing about $27 billion per year in the United States. And here you can see a curve showing the solid line showing all mechanical ventilation from 1993 up to 2009. And you can see that it's been increasing in numbers, especially with the elderly population that are entering the epidemiological state. However, for COPD and heart failure, we're seeing less and less of those, or it's staying relatively steady. Now, the median length of a patient who once gets intubated with mechanical ventilation is about 9 days. And this has been steady for several years as well across all the different causes or indications for mechanical ventilation. Now, the big question is, should you trach or should you not to trach? And all of these are in efforts to mitigate morbidity and patient morbidity and costs as well. Some of the things we're going to talk about is, does traching change hospital stay? Does it change mortality? Does it change the rate of ventilator-associated pneumonias or how many days you're off the ventilator? What's the patient comfort and satisfaction when it comes to the ventilator? And what's the required degree of sedation? Now, tracheostomy is quite an old procedure, and what we're going to be debating today has been ongoing for 200 years now. Back in December 13th of 1799, George Washington developed acute epiglottitis, and Dr. Elisha Colin-Dick suggested to cannulate or open up his airway by going through the front of the neck. His colleagues thought this idea was ridiculous and rejected this. Unfortunately, George Washington passed away the following day. And here's a picture. You could see a painted picture of George Washington on his deathbed, to be more specific. Now, is tracheostomy a good choice in patients that have been mechanically ventilated for 14 days or more? This is a retrospective study that was done back in 2015 from the anesthesia literature. They retrospectively looked at about 551 patients who had mechanical ventilation. Of these patients, they included 500, half of at a 3-to-1 ratio, of which some went intubation and others underwent tracheostomy. Continued intubation versus tracheostomy at day 14 of their hospitalization. The biggest thing they looked at and noticed is that there was a lower in-hospital mortality in patients that received a tracheostomy, and there was a higher success of weaning in the patients with tracheostomy who were intubated for more than 14 days. Now, why are we getting successful weaning with tracheostomy patients? One, there's a concept called decreased airway resistance and work. Two, there's improved removal of secretions as done so through the tracheostomy rather than the ET tube. Perhaps there's decreased rates of ventilator-associated pneumonia with the tracheostomy. Perhaps there's less need for sedation as there isn't a invasive approach into the trachea through the mouth. There's more improved patient care with these patients. Now, going back to decreased airway resistance and work, this falls back to the concepts of Poisson's resistance and flow. You can see here there's a tube with flow represented by F, the radius, and the resistance in the flow, whether it's a gas or a liquid, being the same, and the length of the tube. So the flow rate is equal to the pressure difference times the radius to the power of 4, divided by the viscosity or density of the gas and the length of the tube. One thing, and then if you inverse this and solve for R, you get the resistance to flow. As you want to notice, as you might notice, the resistance to flow is a big factor in terms of the radius more than anything, rather than the length. And then, so the flow resistance is linearly proportional to the density, viscosity, and the length, but it's to the 4th power of the radius of the tube. So the concept is the shorter the tube, the more volume or flow, and the less resistance that you have to work against. And the physiological approach is that there's decreased work of breathing. And this has been clearly been demonstrated in multiple physics-based studies throughout the literature, that there is decreased length there's this decreased work of breathing in the patients with a tracheostomy. I got a question, is less VAP with trach due to change in definition of VAP? Otherwise, actual number of infection are roughly the same. We will touch base on VAP as well later in the lecture. Now, one caveat to this understanding of the physics of the gas is that even though we're seeing it on bench studies, it may not translate to improvement in clinical outcomes of the patients. There are a lot of methodologic flaws in terms of weaning trials that are done. There isn't a consistent approach to weaning trials across different hospitals and protocols, and therefore we don't know if this translates to everyone or there's a confounding factor in terms of the weaning approach of these patients. And finally, these providers aren't blinded to the intervention, so they know who is on a tracheostomy, invasive mechanical ventilation, and who isn't. And they're more likely to discontinue ventilatory supports in patients with a tracheostomy because liberation is as simple as disconnection, and application of an invasive ventilator is as simple as just attaching the tube. Whereas with an ET tube, as you'd imagine, it's not the same. So VAP and tracheostomy. This is a study from CHEST 2001. It looked at the occurrence of ventilator-associated pneumonia in community hospitals and what the risks and clinical outcomes may be. You can see in this are variables for ventilator-associated pneumonias, tracheostomy being the one that is in question. Out of 748 patients, 36 did not develop VAP, whereas 49 had a ventilator-associated pneumonia. So here they noticed that there was an actual clinical and statistical significance of tracheostomy causing VAP. Now, as studies went on and on, they made it clear that tracheostomy is an independent risk factor for developing VAP. However, these studies failed to establish the timing of tracheostomy in relationship to the pneumonia, which is another definition that the CDC has put out in terms of what is defined as ventilator-associated pneumonia. Second, the higher VAP rates may simply reflect that these patients are more likely to be on prolonged mechanical ventilation, and it is a compounding effect, the number of days associated with ventilator-associated pneumonia. Now, this study looked at early tracheostomy in severe head injury. It's prospective, 150 patients that had a TBI. At day 5, they randomized these patients to receive a tracheostomy or continue endotracheal intubation. Now, the T group, the one that received an early tracheostomy, had a nosocomial infection of about 58%, whereas the continued invasive ventilation via ET tube, 61%. This didn't achieve neither clinical or statistical significance. And as you can see, this prospective study was better designed to show the lack of clinical or statistical significance between the two parties. They did notice something else, though, as secondary outcomes, that the patients who underwent tracheostomy had more ventilation-free days. They were liberated from the mechanical ventilator far earlier than those who continued. And they didn't see a difference in the number of weaning attempts as it was protocolized for the hospital that ran this study in particular. Second thing we'll talk about is what is the degree of patient comfort associated with tracheostomy. Now, the reason we're talking about comfort is because comfort is a surrogate of level of sedation. You know, the RASH score will dictate how much sedation the patient will require, which also adds up to a cumulative dose and risk of encephalopathy, leading to further requirement of hospital stay, ICU stay, and ventilator days. Now, this is it's an objective data that's quite limited. Sorry, there's very limited objective data in the literature. This is more of a subjective approach where they polled a bunch of ICU nurses back in 1988, and out of the patients that received tracheostomy, the nurses filled out the questionnaire that they had a perception that the patient was more comfortable compared to prior to tracheostomy. And they also thought that the patients had a better psychological resilience in terms of delirium with the tracheostomy patients. Now, does that truly reflect the amount of sedation that's required in these patients? And this study can help answer that. It's a retrospective study that was performed in a critical care medicine journal in 2005. 312 patients, of which 72 underwent tracheostomy. You can see here, these are the results. This graph A over here on the x-axis is the number of days. T represents the time of tracheostomy placement. And then this is the fentanyl cumulative dose per day. You can see obviously a week prior to leading up to the tracheostomy, the fentanyl cumulative dose was quite extensively high. And once the tracheostomy was placed, you see lower infusions of fentanyl on a cumulative day basis. Here is looking at all those cohort patients before and after, and you can see the significant difference between the two, both of which achieve statistical significance. What about Midazolam? Again, remember this study took place in 2005 where Midazolam was the sedation of choice, whereas now we use more propofol to minimize the ICU-related encephalopathy and delirium. Same thing. A week before leading up to the date of tracheostomy placement, you can clearly see there's a large cumulative dose of a sedative, and soon after, less so. And you can see the cumulative dose before and after for the week prior and after. Both of these, again, achieved clinical and statistical significance. So the impact of tracheostomy is quite profound when it comes to the administration of sedation. Now, big question is, when the tracheostomy was placed, a lot of these patients end up being on a lower PEEP, lower FiO2. They have to be optimized to successfully and undergo a tracheostomy with minimal perioperative risk. Does this mean that the sedation decreased because of the tracheostomy itself, or does this mean that the patients were overall turning around and required less sedation and then received the tracheostomy? It's a question that is posed for this type of retrospective review. Here's another study that took place in 2006, retrospective, 117 patients, and you can see these are different types of medications that are used: morphine, midaz, propofol, and same thing. This is the daily dose accumulation and the percentage of patients, and you can see it started out pretty high and started tapering down, achieving clinical and statistical significance on the day of the tracheostomy across all types of opioids and sedation medications. One thing you should draw your attention to is 2 days before the tracheostomy is done and 2 days after. If you took a subgroup analysis of just this window over here, there was very minimal difference. So again, it goes back to the question, are these patients clinically improving, receiving the tracheostomy and continuing that amount of requirement of sedation. Now, the big question is to trach or not to trach, and when to trach. The biggest factors that go into traching is what is the hospital stay? How is the hospital stay affected? And then we've proven that it decreases hospital mortality, but overall no strong evidence to suggest difference in hospital stay. Now, is this mortality decrease related to patients improving requiring tracheostomy, or is this mortality related to the tracheostomy itself? There's the physiologic understanding that it reduces the work of breathing, and therefore, in theory, you should have more success in terms of weaning. However, it's unclear if this clinically translates into improvement or success in spontaneous breathing trials. Ventilator-associated pneumonia, we've shown that there is evidence that any prolonged invasive mechanical ventilation in its own increases the risk of ventilator-associated pneumonia, but there is no strong evidence that the tracheostomy itself is an independent risk factor associated with the VAP. There's some evidence we reviewed in the traumatic brain injury population that there is an increase in ventilator-free days. And there is a perception a subjective perception from a nursing standpoint that the patient has increased comfort and decreased level of anxiety. So to answer all those questions overall, there's a big study that was performed in Lancet in 2015. They looked at patient getting early versus late tracheostomy, a systematic review. And you can see if you pull this forest plot together, it crosses 1, which means that there isn't a statistical significance in terms of favoring early or late tracheostomy in patients. These patient populations, their definition of early versus late varied across different studies, but on average, they were at week 2, 14 days of invasive mechanical ventilation. Now, a big trial that recently came out, or not recently, but in 2013, is the Trackman Trial, which looked at a prospective approach, randomized, multi-center, controlled study of early versus late tracheostomy. This was done in the UK across numerous hospitals. They looked at 899 patients. They identified those who will likely need at least a week of mechanical ventilation. And they changed, they isolated these patients into 2 groups. One group that will receive a trach within 4 days of mechanical ventilation, and the other group that will receive a trach after 10 days. So this is a pretty strong study to help us understand the outcomes that they were looking for. What's the mortality, the length of stay, and the sedation amount that we've been seeing retrospectively with these patients. Now, they notice no difference in mortality whatsoever when early versus late, no difference in ICU length of stay, early versus late, and no difference in hospital length of stay, and no difference in sedation requirement. So with all those retrospective reviews, as you can see, this randomized trial put that to rest. This trial is very frequently quoted by the surgical group, the ear, nose, throat, and IP as well, that there isn't a difference between patients who will be trached early or late. One thing that's interesting about this study is that the majority of the patients were randomized to the late arm, did not undergo tracheostomy at all. So here you see days from admission to tracheostomy and the percentage of patients. And this is the group that was early tracheostomy within 4 days. A lot of these patients on day 3 received, half of these patients on day 3 received the bulk of tracheostomies. Whereas these patients in the late phase received tracheostomy, about 20% received around day 10. 244 of this patient never even needed a tracheostomy, which means that they were successfully extubated because we waited more than 14 days to decide whether or not they do or do not need tracheostomy. This is a very important driving point, which is what we quote very frequently in terms of guideline, that we should at least wait 14 days to decide whether or not patients should be trached, because of those patients, the majority will never need a tracheostomy. So quick review of everything we've gone over. Number one, there's an underwhelming and weak evidence that suggests early or late tracheostomy favor patient outcomes, such as respiratory infections, sedation, mortality, ICU, and hospital length of stay. Number two, there's strong objective evidence that work of breathing and resistance is improved with tracheostomy, but this doesn't translate to clinical outcomes, and its implications are quite limited. So I'm going to pause there. If you guys have any question, go ahead and post those. Otherwise, we're going to move on and talk about the anatomical approach of tracheostomy placement and how we would manage those. I'll give you guys about 30 seconds. D had asked, did subgroup analysis of the prospective trial show any evidence of benefits in patients with obstructive sleep apnea or obesity hypoventilation syndrome? That prospective trial did not perform subgroup analysis of those patients in particular. Okay, so moving on, tracheostomy placement and its management. There are very strong indications for tracheostomy, one of which being expected prolonged intubation. As we discuss, we would say the 14-day mark is when discussion of tracheostomy should be considered. There's indication of trying to facilitate ventilation and weaning. It's a better pulmonary hygiene as being able to access the airways. If you have any upper airway obstruction, such as OSA, OHS, that meet the CMS criteria, stridor, laryngeal anatomical structure deficiencies, and bilateral vocal cord paralysis. Finally, you have the patients where you're unable to intubate and have to perform an emergent cric or trach. And then patients who obviously have had laryngectomy or have difficulty protecting their airway and secretion load with their swallow mechanism. So the major indication is chronic ventilator dependence, any debilitating neuromuscular disease, any inherited or acquired airway obstruction, emergency situation. The contraindications, there are clear absolute contraindications. I wouldn't say there are any absolute contraindications, but the biggest thing is being able to access the trachea from the front of the neck, which is being able to hyperextend the neck. And then you need at least a centimeter difference of a distance between the inferior cricoid cartilage and the suprasternal notch, as the patient must be able to flex their neck without obstructing or occluding the trach or the stoma against their substernal notch. And then the patient has to be able to tolerate the procedure itself. The definition of what tolerance is varies from institution to institution. The other absolute is if there is an infection, soft tissue infection overlying the access site. The relative ones are coagulopathy, thrombocytopenia, hemodynamic instability, and poor gas exchange. Overall, the consensus is the recommended ventilator settings are a PEEP less than or equal to 10 or an FiO2 less than or equal to 0.6. And this is for two reasons. This is for there is an interruption in ventilation and oxygenation during the tracheostomy placement, and there has to be an available reserve to successfully place the tracheostomy tube, whether it is done in an open surgical approach or a percutaneous approach. PEEP is a bigger factor. As the tracheostomy tract is formed, there's a lot of de-recruitment that occurs, which is something that should be kept in mind in COVID patients. There are three phases of tracheostomy. There's the immediate complications that occurs during the procedure itself. There's early complications that are often described from the end of the procedure to approximately 72 hours. And then there are late complications which can occur within weeks or months of the trach itself. The biggest early complications that you may encounter, which are quite low in terms of occurrence is bleeding, infection, and inadvertent decannulation, a paratracheal insertion into the mediastinal space or esophageal space, injury to the posterior tracheal membrane, a pneumothorax or a pneumomediastinum, and a tracheal ring fracture. Late complications, the most frequent one that we often encounter due to our field in particular is tracheal stenosis, which occurs at the subglottic space most commonly after a ring fracture, or at the level of the stoma, or at the level of the cuff itself. Tracheomalacia can frequently occur in these patients. You can have delayed stomal closure after prolonged cannulation, which requires surgical correction. And then the most catastrophic one is a tracheoinnominate artery fistula formation. It's less than 1% chance of occurring, but when it does occur, the survival rate is quite abysmal with 14.3%. Now, let's talk a little bit about surgical versus percutaneous dilatational tracheostomy. What's the difference? What are the benefits? And a lot of this information comes from a meta-analysis review from Critical Care Journal in 2006. The big thing about percutaneous that offers advantages over surgical is, one, it's a shorter procedure duration. On the average, an experienced proceduralist from incision time to successful cannulation is approximately 1.5 minutes to 3 minutes. It could be performed sooner, and that's because of logistical issues. It's done at bedside. You do not need the OR staff available. You do not need an OR appointment or any availability to be set up. And it's more cost efficient overall. The complication rates between percutaneous and surgical are similar. One thing that has been noticed is that the percutaneous is associated with fewer infections and less bleeding. And that has to do with the approach we'll talk about and touch base on as well. This is just a cost difference between percutaneous dilatational tracheostomy and surgical. You can see the surgical runs at about $3,100, where the percutaneous is $2,600 across different studies. So you can see there's approximately $850 to $1,600 saving back in 2001. The anatomy of the trachea, once you hyperextend the patient, there are certain anatomical landmarks you should be familiar with. And the biggest one is palpate the thyroid cartilage. Right below that, you have the cricoid cartilage in this area here. And then you should be able to palpate the first and second tracheal rings and at least a centimeter distance between the sternal notch and the insertion site. The ideal location of inserting a percutaneous dilatational tracheostomy is in the second or third ring. The higher up you go, the higher risk of tracheal stenosis that may occur. In some patients, unfortunately, we have no choice but to go in the first and second, between the first and second rings, due to the distance from the sternal notch itself. Now, the technique we'll touch based upon that. This is an image of the patient. The head is located here, and the torso is located here. You can see the sternal notch runs right there. What you do is, using your non-dominant hand, you stabilize the trachea, hold it between your two fingers. And then you take a needle syringe, an introducer needle, and you advance it into the second and third, between the second and third tracheal rings. Now, the best way to ensure that is to bronchoscopically visualize the location of the needle. Before you even do that, what we often do is start the bronchoscopy, clear out of any secretions. Then we park the bronchoscope at the end of the ET tube, deflate the balloon, retract the balloon into the subglottic space, inflate the balloon to achieve occlusion, and provide a view of the subglottic space and the first to fifth tracheal rings. And once you cannulate the second and third ring with a needle, there are two ways to do this. You can hold the needle directly, or you can hold a syringe like you do a central line, for example, apply a vacuum against the plunger, and once you get in and lose resistance, you know for sure that you have achieved cannulation of an air space, rather a vessel or a mediastinal space. Then you put a guide wire through. The guide wire tracks into the trachea and parks at the end of the distal trachea, right at the carina. This is called a punch dilator. It helps dilate the incision site at the soft tissue area. You create a punch dilation. Then you come out with the punch dilator, keeping the guide wire in at all times. This is called the blue rhino dilator. The blue rhino dilator is used to achieve incremental dilation. It's tapered. You can see the diameter here is far bigger than the diameter here. And it's got a curvature that follows the trachea and the stoma site. You use this blue rhino dilator to advance in all the way to a marking. And then this is an introducer catheter that remains in, and the dilator comes out over the introducer catheter. So this is a bronchoscopic view of everything that was described here. This here you can see is the needle. The needle is in, it is aimed to the torso, towards the main carina. The guide wire is fed through. And here you can see the guide wire itself. And this is the incrementally dilating blue rhino dilator. And this is the tracheostomy itself coming through the stoma. Now, late complications, that's something that everyone would be exposed to, and therefore this is probably one of the most important things you should be aware of. Obstruction is the most common one. About 30% of ED visits for respiratory distress in patients that have a tracheostomy is due to obstruction. And the most common causes of this obstruction is either dried respiratory secretion, blood, granulation, tissue formation. The other late complication is inadvertent dislodgement. And this happens in the high-risk population, especially the ones that are obese or have a fresh stoma that's defined to have been performed within a week, 7 days. It is not a good idea to try to blindly and forcefully recannulate an immature stoma less than a week, because the risk of creating a false passage is extremely high. And so if you ever encounter a patient that had an inadvertent dislodgement, don't try to put the tracheostomy back in. Just go for an immediate orotracheal intubation as the safest approach. And these patients should be approached the same way a rapid sequence is done. Sometimes you may have difficulty ventilating them or oxygenating them, as the stoma itself is a conduit of air escape. And so what can often be done is that area can be plugged with your gloved thumb while bagging is being performed. A false passage can happen even with a well-formed stoma tract. And it can most frequently happen during the tracheostomy exchange, especially in obese patients who have a lot of redundant tissue between the exit side of the stoma and the insertion side of the trachea. Anytime you see subcutaneous air, you notice crepitus on your exam, you notice distortion of the neck landmarks, a pneumomediastinum, for example. Those are things that would suggest a false passage formation. During the tracheostomy insertion itself, once the tracheostomy is done, the bronchoscope is removed and introduced into the tracheostomy to ensure that the distal end of the trach is located within the trachea. One quick attempt at placing a bronchoscope through the trach can tell you whether you're in a false passage, as you have to identify the main carina and the right upper lobe carina. If you cannot identify those two, you may not be in the airway itself through the trachea, through the tracheostomy. Last thing, a late complication, which frequently happens early but can happen late as well, is a fracture, a tracheal ring fracture. It's very rare. It happens at the weakest point, and that's at the juncture of the flange and the tube connection. If the fracture of the trach happens, the tube can actually migrate into the trachea and cause obstruction. And this should be retrieved bronchoscopically. The cuff can lead into complications. You can have a perforation of the cuff causing a poor seal. You can have overinflation of the cuff causing an esophageal lumen impingement, tracheal mucosal injury, and even tracheal stenosis at the level of the cuff. The most common patients who encounter tracheal stenosis at the level of the cuff are those with microvascular disease like uncontrolled diabetes or hypertension. The best thing to always do is target the cuff pressure to occlusion. So you inflate and you use a manometer until you achieve full occlusion. And full occlusion should exert approximately 18 to 22 millimeters of mercury against the tracheal wall. Anything above 30 to 40 can cause capillary obstruction, blood flow obstruction, and lead to necrosis and complications. Tracheal stenosis can occur in many patients. However, only 10% of these patients will have a clinically significant narrowing that leads to symptomatic manifestation. And most oftenly occurs at the level of the stoma. Less commonly, it occurs at the level of the cuff or the distal tube itself. Tracheoinnominate fistula, as we explained, is very rare but life-threatening. There are two interventions to approach. The best one is to basically take your finger, stick it through the stoma, and pull it anteriorly where the innominate artery is, causing a transmural pressure and tamponade of the artery. Unfortunately, your finger will have to stay in there until this patient is taken to the operating room for exploration. The other possibility is you can advance or adjust the tracheostomy tube and slowly hyperinflate until you're able to create a tamponade effect. This isn't as efficient as the finger, as you know, you would not clearly have a visualization of any active bleeding in this scenario. This is a little card that helps you understand or approach a patient that's having a tracheostomy emergency. I can include this in the PowerPoint that's going to be sent out, and it's something that could be printed out. All right, so next we'll talk about tracheostomy and COVID-19. I'm going to preface with saying that everything that you're seeing here in this PowerPoint presentation is an active flux. There's still ongoing discussions as to what the approach would be with this patient population. As of now, the Tier 1 guidelines are posted. I'm not going to go over all of these. You can see them as needed. The biggest thing I would point out to is that the procedural staff, whether it be ENT, ACS, or IP, will have to discuss directly the case with the ICU attending and confirm the timing. Now, one thing that a tracheostomy, if a tracheostomy is to be done in a COVID patient, the biggest things that we can do is, one, minimize the amount of ventilation that's ongoing. And the best way to do that is paralyze the patient. A single dose of rocuronium would often last about 30 minutes or so in the hepatically cleared patient. And that should be enough to allow them to suppress the cough and minimize aerosolization. You pre-oxygenate the patient and you get everything ready. Once you're ready, you hold ventilation completely and you begin the tracheostomy itself. The tracheostomist and the bronchoscopist or the anesthesiologist should always maintain communication in terms of keeping the cuff inflated as much as possible. You want to minimize suction with the bronchoscopy as much as possible, as the suction valve itself is a source of aerosolization. All these patients should have a cuffed, non-fenestrated tracheostomy to ensure a closed circuit. A lot of these patients should be confirmed. The placement of the tracheostomy tube is encouraged to be confirmed with an end-tidal CO2 rather with a bronchoscope or a suction catheter, again to minimize aerosolization. And then a HMV or HEPA filter should be placed between the tracheostomy and the anesthetic tube or distally to it in the event of disconnection. Post-tracheostomy care, this is a big one. You got to think about the perioperative phase. You also have to think about the post-operative phase. The tracheostomy should not be exchanged unless clinically indicated. Most frequently, we performed our initial trach changes between day 7 and 10 as we anticipate the stoma has resolved by then. I'd imagine with these patients with high doses of systemic glucocorticoid therapy, the track may take longer to do so. And the first change is essentially an assessment by the proceduralist to ensure that the stoma is healing well, there are no false track formations, and so forth, which all of these can be deferred to a later first trach exchange. The cuff should always remain inflated and oftentimes checked for any leaks. Make every effort not to disconnect the circuit and only use closed inline suctioning for these tracheostomies. As of now, the tier 1 guidelines suggest that patients must have a negative result before proceeding with the elective tracheostomy. Again, a lot of these are currently in flux, and we can talk more about them as we finalized the requirements. Now, there are certain ways to minimize aerosolization altogether. The big question is open surgical tracheostomy less likely to cause aerosolization or percutaneous? It depends who you ask. If you ask someone like ENT, for example, the advantage of an open surgical tracheostomy is, one, you can leave the tracheostomy tube distal to the window, the tracheostomy window that's being performed, and therefore keep this area occluded during the tracheostomy window formation. And once you're ready to place the tracheostomy itself, you can hold ventilation for a brief period. I would argue that the window itself will provide profound leak into the airway, and therefore that's at risk of aerosolization as well. Granted, the tracheostomy balloon will be distal to that, and so it's very unlikely that the aerosolization would be from the lungs itself, but rather the proximal tracheal airway. The other argument is that a lot of our patients are on anticoagulation, and some of our colleagues in Barcelona have noticed that they are encountering about a 15% bleeding rate with open tracheostomies on these patients who are on anticoagulation. And by bleeding, I'm talking about day 1 to 3, and bleeding to the point where it's clinically significant, where they need to have to intervene with Surgicel or epinephrine injection, or even re-exploration. One technique that has been developed in Memorial Sloan Kettering in New York is to advance the ET tube to the main carina, inflate the cuff, and maintain the circuit closure. While the ET tube is here, you can introduce the bronchoscope next to the ET tube through the vocal cords to visualize the tracheal rings, perform the tracheostomy through this area while you're maintaining a seal. The one downside is this is the blue rhino dilator. It would have to go at an angle, which is at risk of causing injury to the trachea itself because of the limited space. And number two, if we have patients with larger bore ET tubes, like a Shiley 8 or 7.5, it may, and with a small tracheal aperture, it may be proven difficult to do so. And so once you do all this, right before you're ready to introduce the tracheostomy, you can withdraw the ET tube and introduce the tracheostomy, right, to minimize any aerosolization. There's a YouTube video that NYU has posted outlining all of this. So with that, I'm going to take any questions that you may have at this point.
Well, thank you very much, Dr. Cohen. That was an excellent talk overall with the last recommendations, at least the policies that we have here at the hospital during this pandemia. In general, one of the things that I would like to add on is really there is a scarce literature when it comes right now to percutaneous tracheostomy and COVID patients, as well as in previous epidemias related to SARS or the COV-1 2013 back in 2003. I'm sorry, 2003, 2004. Really, what the literature is not really good about it. There have been only case series in general, as well as some case reports. None of the literature actually included or performed percutaneous tracheostomy. It doesn't mean that it cannot be done. I think it's a lot of things were pretty much a lot of people were scared about the procedures that produce a lot of in terms to minimize procedures that can generate aerosol. And they see percutaneous tracheostomy as being one of them. There hasn't been any study that side by side in terms of a percutaneous tracheostomy versus an open tracheostomy in patients in general, in patients with SARS, including COVID. But that's something that I think we're gonna see in the near future. As you already described, experiences happening in New York and also in other places. Just because of the need of these patients to undergo tracheostomy, things are going to start getting better in terms of number uh, for studies and case series, etc. There is a question here by uh, Nor. Is it universally called Blue Rhino, or are they a company like Arrow which manufacture these kits? Javi?
So no, that's a good question. This kit is called the Ciaglia. I don't know if you can see my screen, but here's a screenshot of the actual kit that we use here at Henry Ford, the Ciaglia Blue Rhino, and it's by Cook itself. There are other tracheostomy trays, but this is the most commonly one that's I'm familiar with and was trained with, and the one we use here at Henry Ford Hospital.
So does anybody have any other question?
And then your
Dr.
second
Cohen?
question was, has IP started doing bedside trachs? No, we have not yet. This is still a conversation that's ongoing, and before we offer it, we want to make sure that everything is there. Mainly, the post-tracheostomy care is a big factor that needs to be ironed out.
One of the things that I want to add on is Abby is just so doing the literature review. What I realize is all the cases that have been described in the past with this sort of infection by COVID, either 2003 or the new one in 2019, they all have been done, or most of them have been done in the ICU. The tracheostomies, even though they were open tracheostomies, meaning surgical tracheostomies, they were done at the bedside. Most of them, some of them, or a couple of them were done in the OR to try to avoid mobilization and transportation of the patient, which minimizes the exposure for everybody. But then another important thing is that all of the tracheostomies were done in negative pressure rooms. So that's something to consider um, in general. At least this is the experience. Again, there hasn't been any randomized controlled trial. There hasn't been any good literature about it, but they've been done in negative pressure rooms, which is important to mention when it comes to this point.
There is one study. Let me see if I could find that basically created their own negative. Um, yeah, it's this one. They created kind of their own negative pressure chamber, as you can see here. They placed these V-shaped um, clamps, placed a drape over here, and inside they have two suctions that are connected to HEPA filters. And then they do the tracheostomy while standing here. You can see the operator standing here, hands under this drape itself, and performing the tracheostomy to minimize aerosolation that takes place within this chamber itself. It's something we could think about if when we get down to these details.
Yeah, you're right. And actually, that's the study that was on in this patient right now, like in 2020. It was described this protocol for a patient with COVID
Yeah.
when they did it. This is a case report.
So Noor is asking, what PPE did Memorial Sloan Kettering and the New York institutions are doing while doing trachs in COVID? In Chinese videos, that show PAPR suits. Most people are using PAPR because that is the most ideal and safest approach. I don't know what MSK is using in particular. I'd imagine it would be PAPRs.
I agree that the use of poppers and what's called enhanced PPE. I mean, either popper or there are other brands in general. There are other actually brands in Canada that they describe. But anyways, the is probably indicated in cases like this. Although, if we just talk about the literature, there were one of these case series in the past, again in 2003 or 2004, described the use of just regular or standard PPE with an N95 and goggles, as well as, of course, a gown and double gloves and foot covers to be used by a surgeon in 3 cases and with no issues on the surgeon, and they actually measure if there was any infection on the surgeons of the participants of the procedure. This is after a 16 days. So again, I think everybody would just go still for a popper just because we believe it's probably sure, but or is better. Uh, Again, there is scarce literature around, but there's just case series or reports that could say that maybe just a standard PPE would be more enough. If you ask my question, my personal question, I would say my personal answer would be to use a popper.
Yeah, I agree.
Is there any other question that for the audience? Okay, that was a really good lecture. Thank you very much, Dr. Cohen. We've learned a lot today. There were good questions from the audience too. Um, so we're going to proceed now with the second lecture, which is ultrasound ICU. Dr. Cohen, you can go ahead and stop sharing the screen. So if the audience can give us a couple of minutes just to set up for the next lecture. Okay, thank you very much. Okay, so we're back now. I would like to thank Dr. Akshay Srikant. He's the ultrasound fellow. Thank you for volunteering to give us this lecture. I'm sure that we're going to learn a lot today from you. This is a lecture that was long overdue for our fellows, and I'm so glad that we're able to accommodate this for today. Dr. Akshay Srikant, as I said, is the ultrasound fellow in the emergency department, and he's going to talk to us about lung ultrasound review. Go ahead, Akshay.
Great. Can you hear me okay?
Yes, I can hear you.
Okay, perfect. Thanks for that introduction, Dr. Diaz. As you mentioned, I'm the current ultrasound fellow and will be starting ICU fellowship this summer. So hopefully we'll get to work with some of you shortly. Before I get started, just want to acknowledge some of our other panelists who are going to be on the call as well. Dr. Clark, Dr. Impanza, Dr. Suzansky, who are some of our core ultrasound faculty, who will be there to answer some questions, as well as chiming in with some teaching points as we go along. And shout out to Dr. Gardner-Gray and Dr. Hurst for approaching our team to collaborate with you guys. We're excited to do this. So here are the objectives we'll be going over for today. So we'll start off reviewing some of the basic principles and anatomy of lung ultrasound, just so everybody has some common terminology when we discuss these findings. We will review a scanning protocol when we're performing lung ultrasound, as well as go over common imaging artifacts that you will encounter when you're doing these ultrasounds. Then we'll get to specifically COVID infections. There's some preliminary data out there, so we'll go through 2 of the studies that are published in the literature that discuss some of the common lung ultrasound findings that we can see. And we'll finally end today with a case-based review with a few different cases. And for that portion, it's meant to be a little bit more interactive. So, you know, the fellows feel free to use the chat session as well as, you know, talk back and forth with us. So starting off with why, you know, do lung ultrasound? A few different reasons. One, it's faster to obtain than a chest x-ray. It's immediately available and rapidly interpreted. I know many of you guys, when you're on your ICU nights, you have patients that acutely decompensate and you need to make decisions right away. And sometimes your ability to do a quick bedside ultrasound is going to be faster and more efficient than even getting the x-ray tech to the bedside and getting your one view chest x-rays. So knowing how to do it and being able to interpret those findings is going to help you clinically significantly. It's easy to repeat and it's less ionizing radiation than chest x-ray. It's cost effective and it's actually superior to supine chest x-ray for a few different conditions listed above. So how does it compare? So this is a table from a paper by Lichtenstein et al. That outlines the blue protocol. And if you consider CT and non-con CT scan, if your chest's your gold standard, you can see that ultrasound stacks up pretty well in terms of sensitivity and specificity for various conditions, whether that's pleural effusion or complete pneumothorax. So first things first, what sort of transducer do we want to use when we're performing a bedside ultrasound? You can see there's a bunch of different options. So to answer that question, it really depends. It depends on whether you're performing a lung ultrasound to look for, you know, certain pathology, or if you're looking specifically for pneumothorax. So generally, if you are doing a lung ultrasound, you'll tend to use a curvilinear or phased array probe, which you could see over here. It's a lower frequency probe. It's going to allow you better penetration so you could see deeper, and you want to make sure it's set to the correct preset. So if you used a phased array probe, a lot of times you can set it to a lung preset. For me personally, when I use a curvilinear probe, I like it to be in the abdominal preset. I think the images are pretty good quality, as opposed to if you're specifically looking for pneumothorax, I would recommend using the linear probe. Your linear probe, you could see over here, is higher frequency and allows you to really evaluate the pleural line pretty well. So patient positioning will matter. Use gravity. So thinking of general principles, fluid tends to sink. So your pleural fluid is going to end up being more dependent, and your pneumothorax generally non-dependent. So you'll see it in more of your anterior lung fields. When you're performing these scans, always look for your surrounding landmarks. So always identify rib shadows. And when you perform these, an ideal image is going to be orienting 2 rib shadows to the lateral aspects of your screen with your pleural line in the center. And we'll go over some examples of that. So in terms of the scanning protocol, what we like to use in the ER, which is pretty easy to reproduce, is dividing your lung into different zones. So we generally, you can see on this figure here, if you have your midclavicular line up here and then your axillary lines, it divides your lung into 4 different zones on the right side, similarly 4 different zones on the left side. And we prefer this because it's easy convention. It's reproducible. And also when you're performing these scans, you can label the images or your clips just with specific numbers, and it provides a uniform nomenclature so people know exactly what zone you're talking about or referencing. And so in terms of the scanning protocol, you could see pretty straightforward, just moving down, starting in each zone. This blue dot refers to your indicator. So your indicator is directed up towards the patient's head, and you can move in a systematic fashion doing each lung zone on the right and left side. And so here's an example from our ER scanning protocol that just shows what required clips you need when you're performing a lung ultrasound. And you could see your zones are labeled 1 through 8, depending on if you're talking about the right or left lung. And some other tips: make sure your depth is at least anywhere from 16 to 18 centimeters. And you move kind of in a systematic fashion to be able to evaluate multiple different segments of the lung. So it's really important when you're doing this that you identify your normal anatomy. So just a quick review. So you could see the image on the right-hand side of the screen. So this correlates to normal muscle, superficial to that. So superficial to deep. Superficial up here will be your skin, soft tissue. You tend to see your pectoralis muscle, intercostal muscle, rib, and there's 2 separate ribs and shadowing deep to it, and then your bright white or hyperechoic pleural line that you can see. And so what you normally look for when you evaluate your pleural line is specifically the presence of lung sliding. So your lung sliding is seen in the area where the visceral and parietal pleural meet, and you could see it's described as a shimmering artifact, which you could see over here. The other thing to be able to recognize is when there is an absence of lung sliding. So you could see the difference between the 2 clips here. You could see your bright white pleural line, and there's really no movement or shimmering like you can see previously. Now, another thing that you can do to help visualize this is using the principle of M-mode. So M-mode allows you to get a 2-dimensional representation over this specific point in time. And so sometimes when you're looking at the pleural line, it may be hard to tell for sure whether or not you see lung sliding, and using M-mode can make this easier to visualize. In this case, you have your M-mode tracing here at the bottom of the screen. And if this white correlates to your pleural line, you could see everything deep to that is your normal lung parenchyma. And it gives off a seashore sign, almost looks like waves on a beach, as opposed to a setting where you have an absence of lung sliding. You can see over here, it is sometimes referred to as a stratosphere sign or a barcode sign, so an absence of lung sliding, and a good way to see whether or not you actually have lung sliding. It's an easier way. And so what does sliding and not sliding mean? So the presence of lung sliding means that there is no pneumothorax. So it's a normal finding. And it's important to point out that the absence of lung sliding does not necessarily mean that there is a pneumothorax, right? You're going to have to clinically correlate depending on the situation. So for example, if you have loss of lung sliding after a procedure, you just did a subclavian central line and you have a loss of lung sliding, that is probably going to be a pneumothorax until proven otherwise. But to definitively call a pneumothorax on ultrasound, you need to identify what's called the lung point. And the lung point refers to the point where the actual pneumothorax begins. And it's an area where you are able to visualize intermittent lung sliding with an area where there is no lung sliding. It can be difficult to find, but if you see a lung point, that's 100% diagnostic of a pneumothorax. And so here's an example of a lung point. And so you could see the clip here on the right-hand side of the screen. So again, you have rib shadowing, your pleural line, and you could see an area where it transitions from normal lung sliding to an absence of lung sliding. And so if you were to see this on a patient, again, this would be diagnostic of a pneumothorax. And just another example that demonstrates a lung point. So next, I want to go ahead and review some common imaging artifacts that you will tend to see when you're performing ultrasounds. So the first imaging artifact will be A-lines.
Actually, do you hear me or no?
Yeah.
So going back to that point, sorry, if you don't mind going back a couple slides.
Yeah, which one?
I'm sorry if I missed it, but so if you have absence lung sliding, it's not diagnostic for a pneumothorax, but it's concerning for one. Is there any other conditions that you think you could see with absence of lung sliding that you want to just mention to these folks?
Sure. Yeah. No. Yeah, I didn't mention that. So you can see an absence of lung sliding in certain conditions. So again, if you have severe consolidation, that's one example. Again, if you just intubated someone and let's say you ended up main stemming them, so it was a right main stem intubation, then that side you may not see any lung sliding. And another condition is sometimes in severe ARDS patients, you may have areas where you're not seeing lung sliding. So I think that's a good point. Especially thinking about the whole clinical situation. So for us in the ER setting, if you have a trauma patient that comes into room 1 after a significant chest trauma and you're not seeing lung sliding over a segment, that is probably going to be a pneumothorax until proven otherwise. So thinking about the entire clinical situation is important.
A couple of other things too that can also do this. If you have like really bad blebs in your lung, so you have really bad emphysema, blebs, you will see absence of lung sliding and there won't be a pneumothorax. And then patients who have pleurodesis after chest, like multiple pneumothorax, also do not have lung sliding.
Great, thank you. So in terms of imaging artifacts, the first one we'll talk about will be A-lines. So A-lines refer to a reverberation artifact. So they will be horizontal lines that are seen parallel to your pleural line, and you could see some of them pointed out on the image on the right-hand part of the screen. And so A-lines are going to be seen in normal lung. Another thing to consider is certain imaging artifact patterns are suggestive of certain conditions. So for example, if you have a patient that has predominant A-lines plus lung sliding, that is a pattern that's generally seen in patients with asthma or COPD, as opposed to if you're seeing predominant A-lines in the absence of lung sliding, you can see that in pneumothorax. And so here's an example of just some normal A-lines. So again, we're seeing rib shadowing, and then you could see these reverberation artifacts that extend all the way across. So the next imaging artifact we'll talk about will be B-lines. So B-lines refer to hyperechoic linear appearance that you see extending from the pleural line and extends the entire length of the screen. And so you can see a single B-line artifact can be a normal finding, but if you have 3 or more B-lines in one lung field, that is considered abnormal. And so multiple B-lines in a single field can be seen in various different causes. So you can see it in cardiogenic as well as non-cardiogenic pulmonary edema, interstitial pneumonitis, or certain lung parenchymal diseases. But I think one point that's important is, again, if you're trying to differentiate between someone who has potentially CHF versus COPD, looking at certain patterns on their lung ultrasound can help you and provide you with some more data. So someone who has a ton of B-lines is probably more suggestive of, CHF as opposed to someone where you're seeing predominant A-lines and lung sliding, probably more likely COPD, again, taking your whole clinical picture into consideration. So here's an example of a clip that just demonstrates various B-lines, and you could see kind of extending all the way the entire length of the field. And so the last imaging artifact that we'll comment on will be Z-lines. And so Z-lines are a normal pleural artifact. Sometimes they're referred to as fake B-lines. And I think this is an important point because sometimes people will see this artifact and mistake it for B-lines. And there's a couple of ways in which you can recognize them as being Z-lines as opposed to B-lines. First is they generally do not obliterate your A-lines. So you can see on the clip on the right-hand side, you're still seeing your A-lines as opposed to the previous clips that you saw your B-lines completely obliterated those A-lines. You lost them in your images. And the second thing is these Z-lines tend to be more shallow. So again, you're not seeing them extending the entire length of the screen. And it's important because again, these are generally a normal pleural artifact, not considered pathologic.
And also the transducer used there was a high frequency transducer. So you only have a depth of about 4.8 centimeters. So when you're evaluating for true B lines in a patient who has pulmonary edema or the interstitial pattern, you want to select a transducer that will give you enough depth. So either the curvilinear probe, microconvex, or the phased array cardiac probe to give you depths of up to 20, 30 centimeters to truly interpret B lines and make sure you're not looking at Z lines.
Great, thank you. So now that we've kind of established a scanning protocol and reviewed some basic ultrasound terminology as well as some imaging artifact, let's talk about some POCUS findings that we're seeing in COVID-19 infections. And so again, the studies that have been published to date, there are two primary studies that are out there in the literature. Both of them were performed in China, and both of them were retrospective studies that looked at 20 patients each with COVID-19 infection. Now, it's important to point out the first study specifically looked at patients that were non-critical. Both studies did use 12 lung zones in their protocol, and the data that we have so far is based on, I guess, this pool of 40 patients. Now, we have been doing ultrasounds in the ER as well, and we are seeing a lot of the similar findings that they mentioned in these articles. So the first thing I want to point out is generally your pathologic findings in COVID-19 infections tend to affect your posterior inferior lung fields. And so in these cases, almost 75% of the cases showed findings in the posterior inferior lung fields, and posterior superior was second most common with about 50% of cases. So you're generally seeing abnormal pathologic findings posteriorly. So the first most common finding that they found in these infections was B lines, either discontinuous or continuous or fused B lines was the most common finding. In study one, almost 38% of patients were found to have B lines. Another important point that one of the studies mentioned was that focal B lines was tended to be seen early on and in mild infection. And again, you could see on the right-hand side, this sample clip, you are in a curvilinear, using a curvilinear transducer, you're in your abdominal preset. You can see your pleural line, and again, this hyperechoic artifact extending the entire length of your screen. So the second finding that they noticed in these patients was various pleural line abnormalities. So one of the things they mentioned was discontinuous and thick appearance to your pleural line, and that was found in almost 15% of patients. And they were also noticing skip lesions, so areas where your pathologic findings were skipping along the pleural line. And so I just want to play this clip here and let me know if you can't hear the sound. This is from Butterfly that shows an example of a patient with COVID infection.
This is a lung ultrasound study in a patient with confirmed COVID-19 infection. We are in a lung preset and we see rib here with shadowing and adjacent rib here with shadowing. This is the pleural line, and you'll notice that there is some isolated B lines here as well as B lines there. During the sliding, you can see that there's thickening and irregularity of the pleural line with some discontinuity of the pleural line right there. And this pattern of thickened irregular pleura with scattered B-lines and skip lesions where you have no B-lines in this space between the two B-lines is a characteristic finding that is emerging with COVID-19 infected patients.
So you can see two major findings that they're referencing. One, the discontinuity of your pleural line, as opposed to some of the previous clips where your pleural line has that nice smooth appearance. And kind of the second finding is this area of skip lesions where you have areas of B-lines and then an area where it's normal followed by additional B-lines. And they were noticing this in a portion of their patients as well. Now, the third finding that you can expect to sometimes see in these patients are small subpleural consolidations. And in study one, this was found in almost 22% of patients. So just a quick review, when you're talking about lung consolidation, there's two primary patterns of alveolar consolidation that you can see on ultrasound, translobar as well and non-translobar consolidation. Generally, your translobar consolidation will tend to give what's referenced as a tissue-like sign or hepatization of your lung. And you can see that on this image on the left-hand side of the screen. So here is your spleen, diaphragm, and all of this over here is likely consolidated lung. And you could see that the echogenicity of it appears similar to your spleen and so or your liver, and so they refer to it as a tissue-like sign, as opposed to in your non-translobar consolidations you tend to get what's seen as the shred sign, which I will show you in the next slide. But I want to play again this clip that shows an example of subpleural consolidation.
This is an ultrasound study using the lung preset where we see rib and shadow, rib and shadow. The pleural line has been obscured by the development of a subpleural consolidation with air bronchograms visible within the subpleural consolidation, representative of a focal pneumonia in a patient with confirmed COVID-19 infection.
And so here's an example of the shred sign, what we were talking about. And what the shred sign refers to is specifically when you reach the boundary between aerated as well as consolidated lung, you tend to get an irregular border or a fractional border, which is represented as the shred sign. So you can see over here, if this is your pleural line up here, this is all normal aerated lung down here. And as you come over and you reach this border, you tend to get this shredded appearance, which is, again, the boundary between your aerated as well as your consolidated lung. And if you look up here, you can see as well this subpleural consolidation.
So that subpleural consolidation is sitting between the parietal and the visceral pleura, which you see in all that shaggy border area with the air bronchograms represent part of the visceral part of the lung, and you have fluid in between the two. So if you see that initial pleural line, that's the parietal pleura. If you extend it across in between those two ribs, that's the parietal pleura. And the visceral pleura is kind of somewhat obscured with all this shred sign that we see down there.
Great, thank you. And another thing to point out is just when you have both your tissue-like sign as well as your shred sign present, it's 90% sensitive and 98% specific for some type of consolidation. And so the other finding they also found was air bronchograms, which Dr. Mpanza had pointed out some of them in the previous clips. They were seeing air bronchograms in about 15.4% of studies in patients with pneumonia. So again, you could see this area where you're seeing multiple air bronchograms and consolidation. The final finding that they mentioned was pleural effusion. Now, they mentioned it was less common to actually see pleural effusions. There was a small percentage of patients that may have small pleural effusions around lung lesions, but it's a less common finding. So the reason I bring that up is, again, if you're not seeing any B lines, you're not seeing any evidence of consolidation, and you're seeing isolated effusions in some of these patients, it probably is less likely related to COVID. And just to point out on this clip on the right, so you could see liver over here, diaphragm coming in, and you could see your thoracic spine and the posterior aspect of your screen and some shadowing deep to your thoracic spine. Normally, your thoracic spine should end at about the level of the diaphragm. If you're seeing thoracic spine extending past the diaphragm, which you see over here, that is diagnostic of a pleural effusion, and it's referred to as the spine sign.
One other thing I want to add in with pleural effusions and having it being less common in COVID. That's less common in COVID in patients in China. So anecdotally, our patient population, a lot of them already have pleural effusions, and all these patients with these chronic comorbidities are getting COVID lung infections as well. So just because you see a pleural effusion, like, it should be on your radar being like, this is a little atypical for COVID, but don't let it skew your decision being like, oh, they have a pleural effusion, this cannot be COVID. Everything is COVID right now. So it's very possible they just have a bad heart with pleural effusions and then COVID. So just be careful anchoring.
Yeah, thank you, Dr. Clark. That's a good point. So again, shout out to Dr. Clark for this image. You could see his nice art skills that he used to draw this on his iPad. So this is our proposed lung scanning protocol for suspected COVID that we're using down in the ED. So you saw the previous slide earlier on, which showed your 8 different lung zones. So since we're seeing a lot of findings posteriorly, we added 2 different zones on our protocol as well. So you could see on the back over here, we added a 5th and 6th zone for both lungs, and specifically using your mid-scapular line as kind of a landmark, and looking posteriorly would be beneficial. And part of the reason we wanted to show you guys this nomenclature is that now we are able to push some of our ultrasound images to PACS. So if you see a patient that's admitted to the ICU and they have a procedure note for an ultrasound done, you should be able to view their ultrasound images on PACS. And so we're gonna label specifically with these labels as well. So you'll be able to know when you see abnormal findings on, L5 or L6, that we're talking about posterior findings. And so it's kind of a uniform nomenclature for us to use. And so some of the take-home points that we want to touch on is that point-of-care ultrasound can be used in patients with suspected COVID infections to diagnose pneumonia, as well as follow disease progression. Just to recap, the most common findings are going to be B lines, followed by pleural line abnormalities and skip lesions, and finally consolidation and air bronchograms. And remember that these findings tend to be bilateral and involve your lower or posterior lung fields. And 2 important points, teaching points that I think is important for you guys as fellows. The first being that consolidation in these studies tends to be progressive, and we tend to see this in more critically ill patients. And I think this becomes important, especially when you guys may have to evaluate patients on the floor and determine whether or not you might need to escalate their care to the ICU. If you do decide to do a bedside ultrasound, if they have B lines plus consolidation on your bedside study, these are people that in some of these studies tended to be more progressively ill. So these were patients that needed ICU, tended to have a higher incidence of requiring a ventilator. So just something to keep in mind. And then the second important point was these studies also suggested that as infection resolved, they tended to see more A lines, specifically during the recovery period. And so this could be something that could potentially be used as you're following these patients and assessing their ability to be extubated. So for example, if you have a ultrasound from 7 days ago that was done in the ICU or in the ED that shows multiple B lines and consolidation, and they've been on the ventilator, you've been weaning them, and you have a bedside ultrasound now that shows predominant A lines, that would be additional objective data suggesting that maybe their infection is resolving. And so something to consider. Again, there's not a whole lot of literature on this. I think we still need additional studies to assess whether or not point-of-care ultrasound can help risk stratify these patients. But being aware of these findings can definitely help, again, provide you with more data points when you're making some management decisions. And so the last part of the lecture, the next like 15 minutes or so, is I want this to be a little bit more interactive. And so we were planning on doing a case review where we go through a few different cases. So I've prepared 2 cases here. And if we have time, I think Dr. Clark has a 3rd case that we can go through as well. And so again, feel free to use the chat box, or Dr. Diaz, if you want to have the fellows be unmuted for this portion, they can chime in as well. But we'll go through some cases.
I will have them unmute for now. Thank you.
So the first case was a 51-year-old female, history of anemia, who presented with shortness of breath. So she initially presented to one of our satellite centers with a 10-day history of shortness of breath and myalgias, was also having sharp pleuritic chest pain, nausea, and emesis. In terms of her exam, she initially was afebrile there. Her pulse ox was 95% on room air. You could see her blood pressure initially was 90/50. She was noted to be anxious appearing and in mild distress with a clear lung exam. In terms of her labs at the outside hospital, so really nothing too crazy. Her absolute lymphocyte count was noted to be a little bit low at 0.9, but otherwise her lactate was 2, BNP was 24. So she was complaining of abdominal pain, so she got some fluids, a GI cocktail, and had an acute abdominal series that was performed. So here's her chest from that acute abdominal series, and you could see they're commenting that she has likely multifocal pneumonia that you're seeing. And so while she was at the outside hospital, she became increasingly short of breath, and pulse ox was 92% on 2 liters. Given these findings, there was concern for COVID, so she was swabbed. She started to require up to 6 liters and was eventually transferred to Henry Ford, Maine for escalation of care. So she presented to our emergency department. When she was there, again, you could see that her heart rate was okay. Her pulse ox 95, now on 2 liters. She was in mild distress and extremely anxious. She was tachypnic, speaking in 2 or 3 word sentences, and noted to desaturate pretty quickly while she was speaking. And so we did a point of care ultrasound. So I want to open this up to some of the fellows if they want to take a shot and try to interpret what we're looking at. So what transducer do you think we're using, and what sort of abnormal findings, if any, do you guys see?
Curvilinear. And the couple, like, I mean, it's B lines. You can see a couple of B lines. It's curvilinear.
Excellent. Yeah, right. So you're
Correct.
So you're using your curvilinear transducer. You could see your preset at the bottom. You're in an abdomen preset, and you can see the depth is set at 16 centimeters. So you're seeing rib, shadow, and again, your pleural line. And you could see this hyperechoic imaging artifact that extends all the way to the end of the screen. So yes, you're definitely seeing some B lines. But in terms of the actual pleural line, again, we label this as 1. So we're looking pretty anteriorly, and the pleural line looks relatively smooth.
Mm-hmm.
So here is the next set of images. And as we move a little bit more posterior, what do you guys think?
I mean, it goes from Z lines to a couple of B lines. I mean, like right now, we see that there are a couple of A lines, but the B lines are not all the way going through. But then later on, when it moves a little bit further, you can see B lines going all the way down. Not sure. I mean, this part, are these A lines? I'm not sure.
Yeah, I agree. I mean, you're definitely seeing B-line. So we're at 4. So again, we're at near our diaphragmatic recess. You can see liver coming in here, diaphragm. And then as you see your pleural line coming in, you could see this pleural line is not as sharp as it was in our previous images. You're starting to see some irregularity, maybe some thickening to your pleural line. And again, you are seeing some B-lines in both areas that extend to the bottom of the screen.
And just to clarify, when you see a pleural line like this, this is where you have to use your scanning technique to try and clean it up or improve it. So you want to make sure that you are fanning the probe to try and get it perpendicular to the pleural line to get your cleanest line. Remember, the chest is basically a barrel shape, and so sometimes that requires fanning the probe to clean up that pleural line to make it better. But in this case, these images were recorded with the best pleural line we could get.
So here's the last set of clips as we move more posterior and now on the left side, so you can see. What do you guys think?
There is probably it's a consolidation, which is like dipping in and out over there, but like below this, the diaphragm, it's too black. Like, is it the spleen which is too? I don't know. Not sure.
Yeah, look above the diaphragm to the evaluate the costodiaphragmatic recess.
Yeah. I mean, is it
talking about pleural line? I'd like you to be a little bit more specific. Talk about visceral pleura
like,
or parietal.
It is visceral pleura, which is coming in and out, but I'm not sure, like, if it's the chewed up appearance. I'm not sure what, like, exact terminology. I'm not remembering it.
Okay, so one thing you can think about is normally the normal visceral pleura, we look for lung sliding, and you look for a nice uniform linear pattern, right, with to and fro motion. So in this case, are we seeing a nice uniform linear visceral pleural line, or is it kind of shaggy and irregular?
It is shaggy.
Yes.
It is shaggy. It's like probably that shred appearance kind of.
That's it. So now you're looking at lung consolidation just deep to that area that's echogenic, and at the border or the transition between the normal visceral pleura where it's nicely aerated and deeper to it where you have the pulmonary consolidation, you start seeing the air bronchograms. Now, you see the same pattern in a patient with, community-acquired pneumonia. You see it in COVID. So it's not like a specific thing for COVID. It basically represents alveolar consolidation with air bronchograms, indicating an infectious process. So based on the clinical picture, in this case, everybody coming in with COVID, we have to assume that's what it is. But if somebody had pneumonia, we're going to see the same pattern as well.
Yeah, perfect. Thank you. And the one thing I didn't do that we could have done is, again, if we had switched to a linear transducer, we probably could see this, you probably would see a nice subpleural consolidation as well. And then, as Noor mentioned, yeah, you are seeing spleen over here. So that, again, that's one of your landmarks when you're looking specifically at your diaphragmatic recess. You tend to see spleen more inferior. And then as you go more superior, so you have diaphragm coming in and then moving more this way as you go into your thoracic cavity. So like that.
And you can also see the parietal pleura, that linear line just below the intercostal area. Actually, you want to use your cursor just to identify. Yes, so that's the parietal pleura. And just deep to that is all that schmuzz with the visceral part of it with some fluid in between the two, and air bronchograms we've seen as well. So infectious etiology, alveolar consolidation. Then the rest is
one other thing I would like. Yeah, sorry. One other thing I want to point out too is once you get your so we're at an 18 centimeter depth right here. So once you get your picture evaluating for B lines, if there's an area of lung that you're concerned about, one of the things that you can do is decrease your depth just to look at that area of concern. So for this case, if you brought your depth down to maybe like 10 centimeters, I mean, it's based on like what you're trying to evaluate. The resolution of this costophrenic recess is going to increase, and you're going to see more detail in that subpleural consolidation as well.
Very important point. So depth adjustment would be indicated if you are doing a QA review. First of all, you increase the depth for overall perspective, but after evaluating and finding pathology, looking at all that, the shred, the irregularity of the visceral surface, can't even make it out, and there's that subpleural effusion or area of anechoic findings as well, you would then decrease the depth to improve your temporal resolution to better evaluate it. Another point also is what Dr. Susanski pointed. You can also change your transducer if you want, specific evaluation of that anterior visceral surface, which in that case, you can select a linear probe with higher frequency to just evaluate that area. But in this case, just adjusting your depth will give you enough information to make that diagnosis.
Great. And so in terms of this patient's hospital course, so while she was in the ER, she was persistently tachypnic, and again, initially was on 2 liters, desaturated when speaking, requiring up to 6 liters, eventually had to escalate her to a Salter at 15 liters. So she was ultimately admitted to the MICU and required high flow nasal cannula. And so just wanted to point out this case that within 12 hours, she went from not requiring any oxygen to being on high flow. And so this kind of case fits the picture where when we're seeing patients with multiple findings as well as consolidation, they tend to become more critically ill and tend to escalate their oxygen requirements pretty rapidly. But she did well. She was in the MICU for 4 days, eventually transferred to the GPU. She was never intubated and was discharged home without oxygen, so did well. So here's the second case that we have. And so this was a 32-year-old female that presented with 2-day history of nausea, vomiting, and diarrhea. And so she has a history of an eating disorder, anxiety, and alcohol abuse, who came in with 3 days of nausea, vomiting, and diarrhea. Also was complaining of tremors for 1 day, shortness of breath, and generalized weakness. She denies any medication use, but per the history, she has a history of multiple alcoholic drinks per week, unable to quantify exactly how much. In terms of her exam, she was afebrile, was a little tachycardic in the ED, was saturating 98% on room air. She was well appearing and anxious on exam. She was tachypnic, but again had normal pulmonary exam. And she was noted to have tremors present on her neurologic exam and abnormal finger to nose testing. So initially when she presented, she had just some basic labs. Her initial labs showed a little bit of an acidosis and initially never had a lactate, but while she was in the ER, she was persistently tachypnic, and so they did eventually end up getting a BBG, and you could see her lactate was 3.1. So they were suspecting alcohol withdrawal. So she ended up having a neurology consultation for these tremors. They also agreed it was likely alcohol withdrawal related. She seemed to respond to Ativan, and the plan was for GPU admission. While she was in the ER waiting for a bed, she became increasingly tachycardic with worsening tremors, eventually started to desaturate, requiring up to 6 liters to maintain a SAT of around 92 to 94. So at that point, they were concerned for possible COVID, got swabbed for COVID, had a chest x-ray, and was transferred to Cat 1. So this was her chest x-ray. So you could see not too impressive. They mentioned maybe some slight prominence of some of her interstitial markings, but no obvious consolidation or anything that we're seeing. So while she was in Cat 1, she was tachycardic, tachypnic, and hypoxic. So we did a point of care ultrasound to kind of better assess her volume status as well as looking at her lungs. And so here are our first images that we have. So again, I'll open it up to discussion as well as our fellows. What sort of, the two major questions, what sort of imaging windows are we looking at? And what sort of findings, if any? So we could start with the image on the left.
Long.
It's parasternal
Long. Yeah.
Any other comments regarding the image itself? Look at the chambers.
I mean,
Image on the left.
I mean, is it mild pericardial effusion, or other than that?
No, there's no pericardial effusion.
Are you talking about this?
The one on the top, all the way in the top when the image moves right over. I don't know. Yeah, somewhere around this area. This thin
That'll
line.
be, yeah, that'll be an epicardial fat pad. It kind of moves in concert with cardiac motion, and normally you see the effusion in the dependent areas as well. So if you're evaluating for an effusion, where are you going to be looking for an effusion in this image, parasternal long axis?
So
where specifically?
The descending aorta, like
aorta should be, yeah.
Yeah.
Go
So
ahead,
it was
yeah.
So like we will look at the aorta. If the effusion is like a little bit proximal to the aorta, it's pericardial effusion, and if it's distal to it, then it's pleural effusion.
Yes. So it tends to, so that pericardial layer, envelops the heart and reflects just above the great vessels. So you would see it in between the DTA, descending thoracic aorta. So I like to be more specific instead of just saying the aorta. Over here in this image with cardiac, you want to say the descending or DTA. So look at the DTA and look at the left atrium and look for that potential anechoic free space between the two, which we're not seeing here. So what you looked at anteriorly sometimes can be confusing as well for a minor or a very tiny effusion. But if you're seeing it there and it's a simple or very small effusion, you should also see a very tiny area of anechoic free space between the DTA and the left atrium. And you see it best during systole, just below the coronary sinus. And that's where you look for tiny effusion in a patient, let's say with pericarditis.
Great. And I do think, again, this area over here that you can see is likely a pleural effusion. And as you guys mentioned, you can use your DTA as a landmark. But I guess big question, what do you think of the ejection fraction or how the left ventricle is moving?
So just by looking at the septal motion, I mean, it's not opposed to the interventricular septum. So I would say it's poor.
Actually, it moves up fairly up towards the IVS, not as much, but if you look at the LV, you can tell that the mid cavity area and the apical part of the left ventricle seems to be fairly dilated and may not have as much motion involved in the apical and mid portions of it. But if you look at the basal segment of the LV, where the mitral valve is, overall excursion seems to be fairly okay. So it's definitely over 40, in terms of percent, in terms of the 40, 45. So there might be some septal, some type of dyskinesia involved in the LV itself. So it's not uniformly contracting. There are areas that may not be contracting as well.
Great. What about the image on the right?
So this is like a parasternal short axis, and maybe the squeeze is not that great, I would say.
Great. Again, and you could see just normal anatomy so we can point it out. So you have your concentric, left ventricle that's up here. You have your right ventricle that's up here, and you have your intraventricular septum that's over here. And as you mentioned, overall, it looks globally hypokinetic. Just when you're looking at it, it looks like the ejection fraction is markedly diminished, right?
Mm-hmm.
So now we move on to this image. So what imaging window is this?
Apical four chamber.
Great. And what do you think of the ejection fraction here?
Or just comment on the LV contractility.
Yeah.
You see segments where you see fairly normal motion and areas where maybe slightly depressed.
Yeah, I think
Takasubo.
it's apical like hypokinesis.
Yes, so the apical area seems to be slightly, that's why in the peristernal long axis image, just looking at the mitral valve, its overall excursion seemed to be fairly okay, less than what you would expect in that dilated LV involving the mid to apical segments. The mitral valve excursion, the E-point septal separation seemed to be fairly good, but it was only concentrated around the basal segment, which is closer to the valves. And you have the mid cavity, then you have the apical segments. So this patient, if the patient, let's say, has an LV aneurysm, this is somebody on EKG that you see persistently elevated, ST elevation from old EKGs, not representing acute MI. Or you may see something like this in a patient with Takasubos as well, with apical ballooning.
Great. And so just a few more images. And so again, looking at the IVC, you can see the IVC coming in, going into the right atrium, your hepatic vein. You could see that there isn't a lot of respiratory variation, but in terms of the measurement, it's not very dilated. It measures about 1.5 centimeters. And then we also quickly looked at the lungs as well. And so you could see as you get more inferiorly, we're tending to see some V lines.
Mm-hmm.
And so in terms of this patient's hospital course, so she initially, after having this echo, had some troponins and other testing done. Her trope was markedly elevated. BNP was also elevated. She was placed on high flow and continued to have frequent desaturations, ultimately requiring intubation. So the concern for this, based on the echo findings, was cardiogenic shock. And the reason we brought up this case was, again, this is something relevant to you guys in the ICU, but patients over time tend to be at increased risk for developing myocarditis. And so being able to utilize, bedside echo as well as their overall clinical picture. So someone with rising troponins or rising lactate, maybe considering that there could be another type of shock going on in these patients would be important. And so she was started on inotropic support, admitted to the CICU. She had a left heart cath the same day, which showed a severely depressed EF, less than 30%. Her calculated cardiac output and index was 1.9 and 1.2 respectively, and had a intra-aortic balloon pump placed for additional hemodynamic support. And again, her COVID testing was all pending during this time. Ultimately, her COVID testing was negative ×2, so they don't think it was related to COVID. She ended up doing well. She was weaned off of hemodynamic support, extubated, had a repeat echo a few weeks later that showed a near normal EF. She did have biopsies done when they took her to the cath lab that were also negative for myocarditis. And so again, they were thinking this was likely a Takotsubo type picture. So I think as a teaching point, this case kind of highlights some of the findings you may see in Takotsubo, but also importantly reviews some findings you may see in patients if they do develop a myocarditis later on while they're in the ICU. So something to consider and keep on your differentials. So that's pretty much everything I have for today. I'll kind of open it up to any other questions for either myself or any other panelists.
You want to go back. Let's take a look at one of the echo images. Not the echo, but the lung window. Yeah, this one. So the one, no, yeah, the left. So the image to the right. So we've looked at some of those COVID cases, and we looked at the visceral pleura. So if you look at the image to the right on the screen, which is inferior left, you'd see the visceral pleura has a nice linear pattern to it. We're not seeing the same shred sign that we saw with some of those COVID cases. And you can actually make a slightly differentiate the parietal from the visceral pleura with that area, a small area of anechoic fluid. So that's an effusion right there. Actually, you want to take your cursor. Yes, right there. So if you were to decrease the depth, that's what they also describe, the Blues protocol, like a quad sign, where you'd see just within that area. And if you decrease the depth and actually have a motion, like a video that's actually looping, sometimes you may see kind of a sinusoidal waveform in that area, which would also be the sinusoid sign in patients who have effusions. So over here, we're seeing the same visceral pleura, but it's fairly uniform, and we're not seeing air bronchograms or anything indicating an infectious etiology.
Great, thank you.
Do we?
You guys don't want, if you don't have any of your questions, I have another case that we can go through. We're going to go over 2 o'clock if we do that. If you guys need to go and take care of your things, feel free to, I'll leave it up to Dr. Diaz. But if you would like, I can still run through a case.
Chris,
Do
I
they
think
have any questions? Do
one-
they have questions, the fellows?
Just one, do we use the number of B lines and guide the diuretic therapy? What's your experience for that?
So what's considered abnormal when you're looking for B lines in between 2 ribs? 2 rib shadows. You need a minimum of or greater than to consider it pathologic.
So 2 to 5, we usually see between 2 to 5 B lines, but if it's more than 5, then that means it indicates a lot of pulmonary.
Greater than 3. Greater than 3.
Greater than 3. Okay.
Yeah. So greater than 3. You're definitely seeing 7 in between 2 ribs. That's significant. But greater than 3, that's pulmonary edema starting, interstitial pattern in between ribs.
And then I would like to caveat that, like the question whether or not you should diurese people based on B lines, take it with the whole clinical picture. So don't take just lung ultrasound. Like if your patient's heart rate's 140 and you look at their heart and their EF is like 100%, like maybe that's not somebody, we're trying to run these patients dry, obviously, especially upstairs after the initial resuscitation, but you still got to take the whole clinical picture because there is cardiac dysfunction in the COVID cases, and there are some patients who are profoundly hypovolemic too. So that's why it's nice to, like, actually second case, like looking at the cardiac function kind of clued you into actually what's going on a little bit more than just anchoring based on looking at pulmonary ultrasound.
So, Chris, thank you very much. Actually, would it be okay if we ask you to present the case? This is very, very educational from this standpoint. So we're really learning a lot.
Absolutely.
We'll keep going.
Absolutely.
Yeah, thank you.
And then my last, and then please, if people have questions as we go, just throw them out and let's talk through it. So my last time I got on Zoom, also, mind you, I don't know if, whatever. I was wearing a white t-shirt and I was like, oh man, I need to like actually dress up for this. So I dressed up for you guys. I didn't turn my video on yet, so let's see if that works.
You don't need to turn the video on if you don't want to. That's fine.
Well, no, I dressed up. Let's see.
Yes, we want to see what you look like.
Yes.
That's what I'm saying. Oh, I'm not the host stopped me. You want to let my video go?
Oh, go ahead. You can share it. Just put share screen.
Okay. It just says it stopped my video. The host disabled video. Whatever, it's okay.
All right, it's working. Good.
All right. Okay, so you guys can see this. MICU COVID
Yep.
image
Yep.
review.
Yep.
All right, cool.
Coming up.
You got to have some comedy, right? So I like this one, the antivirus Norton slap to the face. Oh. I also had like a laughing soundtrack that I wanted to play every time because nobody laughs. So we're talking about lung ultrasound, and you guys all have exports upstairs. I just want to make a plug for how we're cleaning these machines. Typically, we are cleaning them previously with Cavi wipes. In the emergency department this week, we're going to start putting garbage bags over top of them, and you can actually use the machine with the garbage bag on top of it. You can touch through the garbage bag, and you can actually see the screen. Part 2 of that is we've been putting sterile probe covers on the probes that we're using. It's all kind of mitigating infection risk and spreading COVID. Dr. Gardner-Gray kind of mentioned would I switch to a linear probe in the chat? And honestly, when I'm getting the machine ready to go into a COVID room, I'm getting this machine ready with what probes I think I'm going to use. And typically I've been getting the phased array and the curvilinear probe ready. Because if I'm going into the room to do an evaluation, I'm going to do everything that I absolutely need to get it all done. So I'm looking at lungs and heart at the same kind of breath. I don't know why this is. All right, so here's my COVID case. Well, actually, it's Dr. Szanski's and I COVID case. I was working in triage, and we had a 53-year-old male, no past medical history, come in with shortness of breath. He worked at a nursing home as one of the maintenance workers, and the nursing home had multiple positive COVID patients. Stated he just felt sick for 5 days. He had like the standard fevers and chills and myalgias. He had a dry cough. He had diarrhea. He never smoked, had no lung disease, no past medical history. In triage, his temperature was 38.3. His heart rate 93. And at first, he was recorded as being mildly tachypneic, maybe like 24, 25, and kind of escalated. I don't know if it's based on him moving around in triage or being transported up to about 40 breaths per minute. His stat was 93% on room air. His blood pressure was okay. And his cursory exam just showed somebody who is like profoundly tachypneic. So kind of going through differential. You guys want to think about, I mean, like obvious things are obvious, but what do you think? COVID. Just a regular bronchopneumonia, bacterial pneumonia. Non-COVID. Viral pneumonia, viral pneumonia, non-COVID. Those obviously in the pandemic are the biggest thing. My pen isn't working right now, so I'm just going to move on. So in lieu of lung and cardiac auscultation, there's some talk about just using ultrasound just to kind of decrease our time in these patients' rooms. Dr. Shrikant put up this picture. This is our COVID adjusted lung protocol. The bigger thing was, adding these posterior lung segments based on the initial literature out of China. There's only 2 papers, each of them had 20 patients. Let's do this. So what we're seeing here, we're looking at the right lung. So 1, 2, 3, 4. And what are we seeing here? So we're seeing rib, shadow, rib, shadow.
A lines.
In the top left one, is there a little bit of, is there like a little shred sign over there? But is that right here? Yep. So you're seeing irregularity of the pleural line. And you're also seeing like, so you're seeing these comet tail artifacts kind of come down, and it's not as classic as some of the other ones that we're seeing. See how like broad based these are? So this is almost like fused B lines. I think this is a bunch of fused B lines all the way down. One of the papers described this as a waterfall sign, if you read that. But you're right. We have this focal subpleural consolidation right here in R3.
So what adjustments can be made to improve evaluating that area?
Probably change it to linear and decrease the depth.
You don't have to change to linear.
Or decrease the depth.
Yeah, so decrease the depth. That alone will give you a lot of information. So you know that you've eliminated or at least excluded Z lines because those B lines erase A lines and they go all the way down to the depth of 18, 20 centimeters. So that's it, decrease in depth. And now you can see that subpleural area. Go ahead, Dr. Clark.
Yeah, exactly. So that's exactly what we did. The first thing we saw it, and then you're seeing this subpleural consolidation. This is just less than a centimeter, and that's kind of what people are describing as well. Kind of going back to this initial right side as well, you're seeing A-line artifacts up in R1, so you're seeing normal aerated lung. In R2, we're intermittently seeing almost a couple B lines kind of shimmering down right here. Maybe beginning of some over here, but we're not seeing more than 3 necessarily. But it's concerning. We're seeing a lot of B line artifacts up in R3. And then down in R4, we're seeing the liver, the diaphragm is kind of intermittently coming up through here. And you're seeing a very thickened pleural line with some B line artifacts coming off here. So I didn't speed this clip up. What do you guys, like what's another thing that you can kind of take from this clip? Severe tachypnea. Yeah, so you can literally pick up him breathing like 40 times a minute. When Dr. Suzansky and I were in the room, we thought he was just anxious. So we just kept doing we thought he had COVID, and we thought he was mildly anxious. So we kind of did our whole exam and it didn't improve at all, like his tachypnea. So, and again, just decreasing your depth increases your resolution. And you're also seeing some skip lesions here that Dr. Shrikant mentioned. He's breathing so fast, but if you kind of focus your attention to the pleural line, like right through this area, see it like intermittently has these like normal aerated lungs between these B lines. So that is another finding that's concerning for COVID. And what that actually is fixed B lines. So if you think about it, why are you seeing these areas of skipped lesions of the lung? The coronavirus, typically they're suggesting that it's infecting the terminal bronchioles, like the terminal bronchioles and alveoli. So you're getting all these peripheral lesions. And literally when you're seeing B lines in these peripheral lesions, you're seeing consolidated lung with aerated lung and then more consolidated lung. So your B lines are kind of stuck to that consolidated lung. And that kind of makes sense.
So quick question, Dr. Clark.
Yeah.
Sorry. So you said that these, or since it's in the patients with COVID, this fused B lines is one of the signs. So in patients with COPD who are like chronic COPDs, don't we get these lines in them as well? So is it like how do we differentiate? Like, is it COVID specific or not? I didn't get that part. You said that it was COVID.
For sure. So COPD patients should have no interstitial edema. Typically their lung profile is all A lines. So you have a patient who comes in COPD exacerbation, you're going to see no B lines, you'll see A lines in all the lung fields. Mind you, if they have pneumonia, you may see B lines in one of your lung fields or consolidation in one of your lung fields. And that could be a patient with COPD and pneumonia. Now, on the caveat, like if you have a patient in heart failure or flash pulmonary edema, those patients have a lot of interstitial fluid in their lungs. So you're going to see B lines kind of diffusely, very similarly to COVID. Typically, those patients, you won't see subpleural consolidations unless they also have pneumonia. And typically, you're not going to see these skip B lines because the whole lung is filled with fluid. So as opposed to COVID pneumonia, you're having these focal patchy areas of consolidation where your B lines are kind of stuck on that consolidated lung, and where it's not consolidated, you're seeing normal aeration. So that's one way that you can kind of figure it out, but in reality, like, again, it's clinical context.
And sometimes in the
hopefully that answers your answer.
Yeah, sorry. And sometimes in the resuscitation room, we actually use ultrasound to help us differentiate those who may be, you know, primary respiratory or some secondary cardiac problem with pulmonary edema. So you have a patient coming in respiratory rate 40, patient is hypertensive, you look at the medications, patient is on albuterol, and they also on Lasix, and you know, you're thinking, is this CHF or COPD exacerbation, or combination of both? And one thing we can also do in those settings is quickly take a look at the patient's lung windows. And in those with clear flash pulmonary edema, you see the B lines. And those with just a primary respiratory problem, you'd see just A lines throughout. And we tell the pharmacist, hold off on the Lasix, and, you know, let's just do albuterol, steroids to treat the patient. And BiPAP, of course, works. So it's a nice way of differentiating those with primary respiratory from those with secondary cardiac issues.
Thank you. This is also something that you guys theoretically could do when you're evaluating patients on the floor for like code blues too, right? Like, you're not going to get an x-ray immediately. And they make portable ultrasounds that can hook to your phone or tablet or all-in-one devices. So, I mean, you're going to listen to their lungs, but maybe at some point you'll put an ultrasound on bilateral lungs, because literally what Dr. Imponza is saying, we do this in the resuscitation bay, and it dramatically changes management as well. Okay, so this is the right side of the patient's lung. This is the R5, so it's like upper part of the back. You're seeing rib, pleural line. You're seeing some B lines coming down through here. And then R6, you're seeing rib here, rib here, rib here. And then you're seeing a bunch of fused B lines and probably a little pleural irregularity as well right here. So kind of summarize here, we'll go to the next lung. So we're going to go over to, oh man, next. We're going to go to the left lung. So again, like, this is kind of medial to lateral from the left to right. This is L1, L2, L3, L4. So we're seeing rib, shadow, rib, shadow. We're seeing our pleural line right through here, and we're seeing a lot of B lines coming off of it, and that's an L1. L2 sometimes is tricky because the heart's sitting right here, so you may need to like slide maybe a little bit more lateral than you typically would. But you're seeing some irregularity of the pleural line up here, maybe a subpleural consolidation right there. And like, this is more of that like fused B line appearance. In L3, we're seeing rib shadow. We're seeing our pleural line here. And again, you're seeing some subpleural consolidation right through here. And then looking at L4, we're seeing the diaphragm intermittently right here. And you're seeing, kind of similar to Dr. Shrikant's case, a lot of consolidated lung, and all this hyperechoic stuff through here that's moving with respiration is, one, some pulmonary edema, you're seeing some B lines, but also you're seeing air bronchograms in this consolidated lung. Can people appreciate that? And again, crank your depth down and you can see these areas better. So you're seeing this irregular pleural line in L2 with subpleural consolidation. And then in L4, where we were just looking, you're seeing all these lung with air bronchograms in consolidated lung. Now, if you were scanning your patient in the unit and they've been on the vent for like 2 weeks, they're like most of these patients are going to get atelectasis, and oftentimes you're going to see stuff like air bronchograms that are static, meaning when they have a breath from the vent, they don't kind of move in and out through the area, the bronchioles and whatever. When you have a consolidation from pneumonia, typically you'll see something called dynamic air bronchograms, where the air will actually kind of go in and out and you'll kind of watch it with respiration. And then again, going back to the left posterior, so we have the upper part of the lung, we have aerated lung, and you're seeing some B lines right here at the bottom portion. That's A-line artifacts, so it's normal aerated lung kind of towards the apex. And we know it's towards the apex. How do we know like this side of the screen is towards the apex?
Of the blue pointer.
Yeah, so here's your indicator, and we're kind of perpendicular to the ribs, so you know this is towards the patient's head. And then kind of going into L6, we're seeing some irregular pleural line, a lot of B lines as well. So kind of when you put it all together, and this is the kind of the whole idea of the blue protocol as well, you get like these different profiles, right? This patient has a profile of scattered B lines, I would say in the majority of the lung fields, with at least 3 lung fields with subpleural consolidations. That's kind of what we wrote. Again, like you're going to see our procedure notes for thoracic ultrasound. They're going to be under the procedures tab if you're kind of trying to see, and then we're trying to push all these images to PACS. This patient, we also took a quick look at the heart because we were in the room. We don't need to belabor the point, but his ejection fraction looked okay. He didn't have a large pericardial effusion. His RV was maybe a little bit enlarged, but the RV systolic function looked okay.
Normal TAPSY.
Yeah, so we talk about TAPSY. We see the tricuspid annulus right through here. We can put our M-mode cursor through that annulus and we can see the amount of displacement with contraction. And that's our TAPSY, and 17 millimeters is our kind of normal cutoff. Should be more than 17 millimeters of displacement. And after you look at a bunch of echoes, you can kind of just appreciate that this is moving quickly and being displaced a fair amount. And then last is IVC. So he had a small IVC, 1.19. So anything less than 2.1, with over 50% respiratory variation corresponds to a CVP of typically like 0 to 5. And again, like kind of break it into less than 2.1 or greater than 2.1, and then less than 50% or more than 50% respiratory variation. You can kind of estimate a CVP. And again, that changes based on if you're on positive pressure or not. So kind of going through here, we put him on oxygen and moved him to category 1 for his tachypnea. We sent the COVID panel of labs. He got an EKG, chest x-ray. And because his RV was slightly dilated, we wanted to scan his chest as well. He got IV fluids, antibiotic, steroids, hydroxychloroquine. Here is his chest x-ray. It kind of matches what our concerns were, like if you're thinking about our ultrasound. But it's kind of interesting as well with the ultrasound because like we saw focal consolidation up through here. You see any consolidation in this area? I mean, it's not as obvious as down here, but it really goes to show you, especially in dry patients that you give a bunch of fluids to, maybe in 8 hours or 6 hours or whatever, their chest x-ray will blossom a pneumonia that you may miss. And it just kind of goes to show you that a lung ultrasound picks this up earlier. Here's his EKG, heart rate at 88. I mean, I'm not going to go through this as well, but no obvious cardiac findings. And then here are his labs. I didn't have my laugh. Oh, thank you for the chuckle. White count 4.9, little lymphopenia, throat BNP normal, CRP 21.5, ferritin 658. Procal was 0.49 and this dimer was only 1.15, and he was COVID positive. These are kind of going through his chest CT. The left is the mediastinal view, the right is the lung view.
Yeah.
And you're seeing these significant basilar opacities, no pulmonary embolism. And even like our one subpleural consolidation was like up in this area. See that little guy that kind of went by?
Tiny.
So, so the patient maintained oxygenation. We consulted you guys and you came down and agreed that he improved with oxygen and fluids. He was placed on a 6-liter Salter and he went to the GPU and he did fine on the GPU. With that being said, whenever we have these subpleural consolidations, and especially if we're seeing them in more than one area, they're typically sicker patients. Obviously, this patient did well, but I've seen very similar patients require oxygen within 12 to 24 hours in ICU transfer. At this point, I don't think, I really agree, like this patient was fine to go to the floor. The respiratory rate improved with oxygen. Just be a little mindful when you're seeing, like what Dr. Shrikant said and what we've kind of been saying, when you're seeing all these subpleural consolidations, their CT typically will look like something like this. So just make it like raise your spidey sense a little bit higher than just usual, I guess. Anybody have anything else to add?
Good.
Well, that was, yeah, so that was a great presentation, really. Any questions you guys have? Anybody else you want to add on? Anything? Well, so I would like to really give thanks to Dr. Shrikant, Dr. Clark for such a great presentation. The cases, we really learned a lot today. And of course, also Dr. Amponsa and Dr. Susansky, who answer questions and pretty much enlighten us with their experience. Thank you very much. This was really a great educational experience for all of us, and we'll looking forward to keep working together. Thank you very much, everybody, for joining, and we'll see you next week then.
Wonderful.
Thank you, Dr. Diaz.
Thanks so much, Dr. Diaz.
Thank you.